Good afternoon, everybody. Dr. Michael Jacobs here at the Fertility and IVF Center in Miami for our Monday afternoon Instagram chat. Today's topic is choosing to use donor eggs. When is it right for us? And this is a great question that often comes up in a bunch of different circumstances. So we'll try and make it simple, easy to understand, and hopefully help you guys get a sense of when this needs to be considered and how to make a decision to move forward and feel good about it. We can break this down into two different reasons why people need donor eggs. The first category is what I call the obvious reasons, and the second one are the less obvious reasons. The obvious reasons, for instance, if we have a single male or a male-male couple that is looking to have a baby using third-party reproduction. Obviously, based on their social choices, they're going to need to use a donor egg and a gestational carrier. And that way they can get the three pieces of the puzzle that need to be put together properly to have a baby, which is having a good source of sperm, a good source of eggs, and a healthy uterus to put them in. So that's a pretty simple one. On the female side, a similar kind of approach is if you have somebody who's in menopause, and menopause doesn't necessarily have to mean a natural menopause because you're 50 years old. It can be somebody whose ovaries just stop functioning at an early age, who had premature ovarian failure. It can be somebody who's had a surgically induced menopause, meaning that due to ovarian cysts or cancer or whatever reason, they've had surgeries and their ovaries have been removed. Or they can have ovaries that just don't work, even though they're still in place, and this could be secondary to exposure to radiation or chemotherapy in the treatment of different cancers. So in a situation where there are no eggs, just like in a male where there's no sperm, you have no choice but to use a donor. And in those cases, it's usually found very easy for couples to accept this because they usually understand going into the thing that they have a problem with producing eggs or needing eggs. And so the choice of a donor is commonsensical as well as one that's both logical from a medical standpoint and it's easy to accept on a personal side. The less obvious indication for using donor eggs is when there's diminished ovarian reserve. And this can show itself in a couple of different ways. If we look at how ovaries function, we know that the younger you are, the more eggs are in the ovary and the better these ovaries are going to function. They'll respond better to lower doses of fertility drugs. When the eggs are retrieved, we get more eggs. When the eggs are fertilized with sperm and develop into embryos, a higher percentage of embryos are normal, meaning if you do genetic biopsy of the placental cells around the outside of the embryo, these trophoectoderm cells when biopsied will reflect what's going on in the actual baby 98% of the time. And what we see is that when you're older, you tend to make a higher percentage of abnormal embryos, and as such, it's harder to get pregnant. So when there's diminished ovarian reserve present, the question is always, well, do I try with my eggs or do I not try with my eggs? And so it comes down, do you do testing of ovarian reserve with AMH level and FSH and estrogen, antral follicle count, ovarian volumes, age determination, and you can go empirically. We know if you're older or younger with less ovarian biologic markers to suggest that you have diminished ovarian reserve, odds are you're going to have a lower chance of success per cycle that we put you on fertility drugs. At the same token, though, if we're lucky to get normal embryos, then the success rate goes way up, even though you've only had a limited number of eggs develop. So it becomes a much more difficult decision. And so just deciding on an empiric basis alone, the practical side is any patient who's 43 or 44 years old is going to always do better with donor eggs. But we have a fair number of these people that produce eggs, and occasionally we get babies from this. It's just not as common as when you're 33 years old. And the question then is, who's to decide? Is it my decision or your decision? And it really becomes a conversation of informing you what our expectations of success are going to be, and as the patient, as the couple, to decide, does this make sense to move forward and try or not. So the first category of less obvious is the ones where we've done some testing and we have an indication that there's less ovarian reserve present, but we really don't know what's going to happen when we stimulate somebody and what the outcome is going to be. And most couples, in having done this a long time, really have a need to try with their own eggs. That's why they come to us in the first place. And it's easy if a couple is, if the woman's 46 or 45 years old, then, you know, the chances of having a biologic child are very, 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 very low. And in that case, one can say, well, maybe we should just go to donor egg and not even bother trying with your own eggs. But it's less so when you have somebody in their 30s with diminished ovarian reserve, or even early 40s that has good ovarian reserve. And so you have a large group of patients where, we may get lucky and produce a good number of eggs, or have a limited number of eggs, but have some of them be normal. So most patients, I found, want to try with their own eggs first. But if you're 45, 46, and your ovarian reserve testing suggests that the biologic markers are showing very limited response to fertility drugs as expected, and you're not going to produce many eggs, and a high incidence of aneuploidy when these eggs are fertilized, you really have to think, does this make any sense? And if you have an unlimited pocketbook and can do IVF multiple times, and it's not going to affect your ability to obtain your end result, which is a baby, then fine. But if you've got to balance these things a little differently, then maybe it's not the best thing to do, and maybe one should think going directly to a donor makes sense. And then you have the second subcategory in this group with diminished ovarian reserve, are patients who've actually been treated. Patients that have been on fertility drugs, or even a cycle of IVF or 2 cycles of IVF. And more commonly, there'll be patients that don't produce a lot of eggs, and when you get the embryos, you're not getting a lot of normal embryos. You're not getting a lot of what are called euploid embryos genetically. And then this just becomes probably the most difficult group of patients, because you have a situation where we know there's going to be less response, there's going to be less eggs to work with. And if you're 42 years old, we know 75% of the embryos that form are not going to be normal with your own eggs, but some of them might be. So at what point do you say, okay, I had enough, I want to move on, or I want to try again? And, we always try and, change the stimulation around a little bit if we can. We try and outfox the ovary best we can to get as many eggs as we can. But at the end of the day, it's a matter of, are you going to make normal embryos or not? And it's a matter of how often, how many times you want to put yourself through an IVF cycle before going, maybe this isn't the best option. I've had young patients who produce 5 and 6 embryos come back all abnormal. I've had older patients that are 43 produce 2 embryos. In one cycle, I get 2 normal embryos. In another cycle, I get no normal embryos. So this can bounce all over the place. And so there aren't any definitive answers, and that's why it makes it more difficult for couples to decide. So if we take these various parameters into account, how do we, as a doctor, and how do you as a patient, come to a decision on what to do? And basically, I look at it that there are 3 parts to this decision triangle. You can call it Dr. Jacobs' decision triangle, but there are 3 parts to it. The first rule of medicine has always been do no harm. And as such, we would never recommend a treatment to you that we thought would expose you to any obvious harm medically, harm socially, harm psychologically. So treating you again, trying another cycle, trying different fertility drugs, none of that's going to create anything that we consider to be harmful to your health on a long-term basis. The second part of this triangle is the psychological aspect. And that's different for every couple. Most couples need to try once or more than once with their own egg before they're ready to accept the fact that my ovary is not cooperating with me. It takes a while to get beyond blaming yourself and realizing that this is nothing related to you. It's not relating to not trying. It's not relating to not wanting. It's not relating to not hoping enough. It's just related to the fact that ovaries that don't respond well to fertility drugs don't produce a lot of eggs. And if you don't produce a lot of eggs and you're older, you tend to make a lot of abnormal embryos, and a lot of times we won't have anything to transfer. So on the psychological side, you've got to sort of balance, am I going to feel okay going to a donor egg, or am I going to second guess this forever and ever that I didn't try hard enough or anything else? From a practical side, it's all relative how you answer that question. I can tell you that if you've gone through 2 IVF cycles or 3 IVF cycles with injectable fertility drugs, between the medications, the treatment, the up and downs of the emotional highs and lows of going through a treatment cycle, I don't think anybody who's been through 3 IVF cycles should ever second guess that they didn't try hard enough, no matter what the outcome might be. So you've got to give yourself credit for what you're doing and not beating yourself up for what your ovary is not doing or not cooperating. And then it's a matter of, okay, if I move on to donor egg, am I going to be happy and be able to look at this and not look back and go, I wish I did that and I wish I did this? Because once you make that decision, we've got a great chance of getting you pregnant if you have an ovary that's not working well, and now we're using a young person's egg to get you pregnant. So, hopefully we're going to get to that goal of having a family with a lot less physical and emotional trauma of continuing to treat you and have disappointments and so forth. But each couple needs to balance that. I've only had a very limited number of patients over 30 years of doing this come in and go, I just want the statistics and I just want to know what the numbers are, and that's what I'm going to go with. Most patients want to be the one to succeed and want that opportunity to be the one to succeed. But how often do you want to hit your head against the wall before going, maybe this isn't working, I need to do something else? So, the first corner of the triangle is do no harm. The second corner of this decision triangle is the psychological aspect. And are we doing you any good psychologically going through more treatment if we know it has a lower chance of working, or do you need that in order to then be able to make the decision to go, okay, let's move on to something else? And the third part of the triangle is the one that's the most frustrating to deal with, is just the financial part of it. Because we all know IVF is expensive. Some patients are lucky to have fertility coverage to let them to do whatever they want. Some patients who have coverage have either choice cycles or dollar fixed amounts, and the insurance companies let you do what you want with it and don't put limitations on it. Other insurance companies say you can only use it for your eggs and not a donor egg, and so forth. So it's all very different depending on the individual, but obviously the finances play a role as well. And I always suggest that one way of looking at it is, if spending money to do treatment A is going to prevent you from doing treatment B 3 or 4 months from now, where treatment B has a 10 times better chance of working, or even a 30 or 40 time chance of working. If you're 44, 45, and our chance of being successful with IVF is having a live baby is 1%, and if you use a donor egg, it's over 50%. The donor egg is 50 times more effective, and it doesn't cost a whole lot more. So it becomes almost a no-brainer from a financial decision standpoint that donor eggs becomes a much more cost-effective way of expanding your family, having a baby, than pursuing treatment when you're not producing many eggs or having good quality embryos. So the third part of this triangle obviously is the financial part, and if the best way to answer that aspect of it is, if I'm not successful in this treatment, do I still have enough reserves either in my discretionary income for my insurance coverage or combination thereof to do the treatment that's most likely going to work, which is to use donor eggs. And in each couple, it's how that triangle spins around, basically. The answer is combining those 3 points of the triangle, those 3 decision trees, really. Do no harm, psychological, good versus bad, financial, where is it in the big picture, that really helps answer the question, should I do this with my own eggs again, or do we just move on to a donor from that standpoint? And we're here to help you and answer your questions. We can guide you, we can give you information on expectations of success and not success, but at the end of the day, it becomes a personal decision of, I need to do this, or I need to do that, or I'm ready to do this and I'm ready to do that. And how the need to and ready to balance out is how you end up making the decision. So that's basically it. A couple questions came up on this of freezing eggs in general. If you're freezing eggs, the best time to do it is younger rather than older. Under age 40 is best. Once you get beyond age 41, 42, the cost-benefit ratio is not very good, particularly at age 45. You're not going to get very many eggs, and if you would need probably 50 eggs cryopreserved instead of 15 at someone at age 30 to have a chance of getting a baby out of it. So the younger the better. The sweet spot for egg freezing is early 30s up to age 40. Beyond that, we have frozen eggs in early 40s in some patients, but the expectations would be much more limited. Costs of all these things are best addressed directly with our business office. When you're talking donor eggs, you're looking at issues related to, are we using a designated donor? Are we using a friend or relative as a donor? Are we getting eggs from an egg bank? And that's, again, whether we're using fresh or frozen eggs is a whole nother discussion, and we're happy to go through that. But if you contact our office, if you're a patient of ours and you want to know the costs, we'll be happy to share those with you. But please talk with your doctor as to what's the best way to proceed, because there, as with all treatments, there's a lot of variations on the theme. But in general, if you look at costs for a donor egg versus costs using my own eggs, if the chance of success is 40 times higher using a donor egg and the treatment costs 20% more, the math works very easily that from a financial standpoint, donor will always make more sense financially relative to the number of babies being born when you're dealing with very diminished ovarian reserve. So, to summarize things very briefly again, you've got obvious reasons why you need donor eggs, in that there aren't any eggs to work with, and there are less obvious ones or less clear decisions to be made when there's diminished ovarian reserve or poor reproductive history. And then you have to get into that decision triangle, balancing the do no harm, psychological benefit, and financial ability to really decide which way to go. So I hope this has been helpful, and please feel free to address it with myself or your individual physicians. And have a good afternoon. Wishing you the best on this Monday. Stay safe. Take care.